Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Programme, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He is on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection or AI software.
It's my responsibility to take the examination in terms of position the patient, then we'll collect his samples. CAD for TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there's any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
Hello all, welcome to the first Delft Imaging webinar. I'm Katyayini Singh and I'll be your host today. According to the recent Global TB report, an estimated 10.6 million people developed TB worldwide in 2022. Unfortunately, TB caused an estimated 1.30 million deaths in the same year. These painful figures underline the urgent need to scale up TB screenings and ensure timely intervention and treatment for all. With this in mind, today we'll be discussing digital X-ray and CAD in action, the real-world impact of TB programs. Next slide, please. Next slide, please. Today, my colleague Florent Geerts and I will be joined by an esteemed panel of speakers who will discuss the impact of deploying digital X-ray and CAD in TB programs across the globe. But before I introduce them, let's note a few instructions. This webinar is being simultaneously interpreted in Arabic, French, Russian, Spanish, and Urdu. To listen to your preferred language, I request you to please click on the interpretation button and select the language of your choice. Also, this webinar will conclude with a Q&A in the end, so I request all our listeners to please put your questions in the Q&A section, where our team can respond to them and discuss them with the panelists in the end during the Q&A session. You will get a copy of the Q&A in the written format as well. Without much ado, let me introduce you to our speakers. Next slide, please. We have Mr. Julius Tumwine, the LabD expert team lead, and the connectivity focal person from NTLP, Uganda. We have Dr. Jean-Pierre Kabuayi. He is an expert in TB epidemiological surveillance from the Ministry of Public Health, Hygiene, and Prevention in DR Congo. We will also be joined by Mr. Sohail Siddiqui, the country head from Pakistan's Omni. And last but not the least, we have Dr. Adeel Tahir, the Director TB Program, Mercy Corps, Pakistan. Next slide, please. Without further ado, I would like to invite Florent to present. Florent, the floor is yours.
Thank you, Katja. I'm happy to do this introduction to our webinar. And I'm very grateful to everybody today, especially our speakers and all of those who are attending the session today, because I know it's a very busy week with the World Health Assembly going on, of course. and I appreciate everybody taking their time and making their time for this session. The theme of this week's World Health Assembly is Health for All for Health, and that is something I think that resonates also very much with our own activities and our vision to make quality healthcare accessible to everybody around the world, regardless of where they live. Because there are still many people losing their lives because of TB, and also during pregnancy, another aspect that we focus on as an organization. And that is something that we work every day to bring quality healthcare to those people as well. Next slide, please. Next slide, please. And we do this in various countries around the world, and we see especially still the interest being scaled up in portable X-ray, mobile X-ray, and also stationary X-ray, like here in Syria with IOM, here in the Philippines, or with SMRU in Thailand. And next slide. The same like here in Tajikistan, also in Nigeria with teams from KNCV and IHVN, and also here in Uzbekistan. And we see, again, especially when it comes to the portable X-ray part, the backpack X-ray, the Delft Light here, and CAD solutions, we see that coming up much more, and they're very much in demand. And I think that's why it's important to have these sessions to share knowledge from the different speakers. How are they utilizing it in different languages, so that different settings and countries, so that others may benefit from their experience. Because if you go to the next slide, please. Right now, we see that there's a lot of organizations and ministries that are just starting out with utilizing some of these digital X-ray systems and CAD. And some of them are starting out with 1, 2, maybe 5 systems, but a number of these are also, with partners of ours and clients around the world that have had a lot of experience, built a lot of experience already working with these systems for a long time, and are really starting to scale up in their utilization. So, for example, highlighting just here as a case study in Nigeria, currently we're rolling out 200 Delft Light portable X-ray with 200 of the CAD-FTB artificial intelligence installations. And we wanted to also take this webinar to give you an idea of how these types of projects work, and to give a perspective from some of our partners that I will speak today, and also from our side. And so the way that we organize it is that the assembly is rolled out across 8 batches. It's a very big project, something like this, for example, Nigeria, of course. So we try to do it in a batch setup. The batches will be transported across 8 different series, transported to the country, who can then also accordingly prep themselves for the training and installation that's about to happen shortly after that. So bringing the necessary people on board, making sure that the whole roll-up plan is set on their side. It's a project in this case which is supported by our Delft Imaging Nigeria partner office, so our local office that will help with the rollout to support KNCV, in this case KNCV Nigeria, with the rollout of this project. And in this case it was implemented by a single procurement agency, but there's also other cases where we collaborate with different procurement agencies around the world for the distribution and the rollout of these solutions. So for example, in Pakistan, we recently, at the end of last year, already started with the rollout of 104 Delft Light portable X-ray and 57 of the Mac mobile X-ray, so the ones that you'd use in an emergency ward. And all of those, so 161 sites in total, have the CAD-FTB artificial intelligence software. Here we worked with multiple procurement agencies at the same time, rolling it out simultaneously, and also working out with our local partner on the ground, Omni. And here on the right side, we can share it also perhaps after, but maybe interesting for those that are interested in how procurement agencies work on these types of projects. Partnership for Supply Chain Management also covered the project in that was implemented in Pakistan. And I'm very grateful, especially also today, to our different speakers, including from Pakistan, also Dr. Adeel and Mr. Sohail, our partner on the ground, that will also give you more of an idea of how these projects are implemented from the case of Mercy Corp implementing this on the ground, and also Mr. Sohail as our partner on the ground, and how they approach training and installation. If you go to the next slide, please. I think when we talk about, and we're really looking at, the impact of these solutions. And it's good to realize that a lot of the impact that we can have with these types of innovations on the ground actually happens after the initial delivery. Because of course, the first step is really to bring the right solutions on the ground, whether it's the setting requires portable X-ray or mobile or stationary, to work with the artificial intelligence. But the real implementation or the real impact after that starts with, training and capacity building and organizing that the right way, and doing that also with the right after sales and support services. So in our case, what we organize, especially on the Delft Light, is 3 times a year we have refresher training sessions in multiple languages, that those are translated, and people dial in from all around the world. Because of course, what happens in a lot of cases in projects is that people tend to think of a training that you do once you receive these new tools, but people don't think about as much as what happens when, new people join, whether it's the ministry or the NGO that is in charge. You also need to train those people. So that's really where the refresher training sessions come in. We do 2 times a year preventive checks also on the system, so people dial in for that. And we also translate it into multiple languages at the same time. And basically, we help them through a troubleshooting procedure that at the end, if it's not successfully done, so there could be an issue, there's also automatically a ticket created at the end so that our help desk can support with that. Then there's e-learning to further build on the capacity building means that we do at the beginning of the project. So looking at, for example, e-learning on a product level. So really, if you're just new to the project, maybe you're coming into it as a radiographer or as an IT specialist a year after the initial implementation. There are still also e-learning modules that you can take on how the products work, what to watch out for. But we also recently launched a new e-learning course specifically on the interpretation of X-ray images. So really to build capacity on the ground on how to interpret X-ray images specifically for the application of TB. So we're really focusing on having good support capabilities, and especially also across hard to reach regions of the world. So I mentioned Syria before. I'm very grateful that we have today Dr. Jean-Pierre from DR Congo talking about how they implemented different X-ray systems under the new tools INTP project that was implemented by the Stop TB partnership in USAID. Because of course that's the most important part, because being able to support these kind of systems in a capital city is one thing, but they're, especially the portable ones, really designed to be implemented in the more remote corners of a country. And also there, of course, support is required, and that isn't always easy. So that's why it's also good to look at these learnings together in a webinar just like today, to share learnings and to see how we can benefit from that. And then the other part is, what can we do once we have these systems in a country? So let's say, for example, well, maybe we take the example of Uganda. We have Julius here today later talking about linking and integrating different X-ray systems with AI software to national surveillance systems or laboratory systems that are in place. Those are also things where we can get additional impact as implementers in these projects even after the delivery, because by linking these X-ray systems and the AI software to existing surveillance systems in the country, we can get better insight on where hotspots might be located, where systems might experience issues, where they're finding the most cases, and so on. So a lot, again, of the impact that we can achieve with these tools is actually achieved after the initial delivery. And then, of course, there's the aspect, at least there is for us, but we do that in cooperation with our partners. How do we continuously improve these tools based on the feedback that we receive from our clients around the world, whether that's on the Delft Light X-ray side or on other X-ray systems that we have, or on the CAD4TB artificial intelligence part. So these upgrades, especially on CAD4TB, are also made available to everybody that has a warranty contract on the CAD4TB still. So as soon as new versions come out, new features, people will automatically be given access to these. So if you go to the next slide, please. Wanted to give an example here of now one of the newest features that we're rolling out is that the CAD for TB platform is now available in 12 different languages, because we've seen that, you know, of course, in a lot of cases, English might be a preferred or workable language. In other settings, it might not be, especially not for some of the users working in remote areas. And then it's, of course, very helpful to be able to interact with the platform in your local language. So whether that is here, you know, I've put Russian as an example. We have Bahasa Indonesia on the bottom left, and also here in French, to be able to work with those localized versions. So that's also these things, you know, that we work on and that we improve the software based on feedback from our clients, and that are then made available and being rolled out. Next slide, please. So as an introduction to our topic of today, at the end of the day, it's really about how can we achieve impact by utilizing these systems. And that's something that, you know, we play a role in there as the provider and developer of these X-ray systems and AI, but we very much rely on, you know, our partners on the ground and the actual work that they put in, of course, in the field, and their feedback and your feedback also today on some of these aspects is invaluable to make our solutions better in future projects. So at the end of the day, driving real impact is really about continuous improvements across the whole cascade of the implementation, whether it's the hardware, the software, you know, what else can we do on capacity building, and what could we do more on service and maintenance that would help your setting on the ground. So again, I'm very grateful to our speakers and everybody from around the world dialing in during this busy week of the World Health Assembly. And I will see you again later in the Q&A, and I'll hand the floor back to Katja. Thank you.
Thank you for your insight, Florent. It's quite interesting to see the kind of impact our solutions are able to create with the help of our partners on the field. On that note, I'd like to invite our first speaker. Next slide, please. Yeah, I'd like to invite our first speaker, Mr. Julius Tumwine. Julius Tumwine is the lab expert team lead and the connectivity focal person in NTLP Uganda. Today, he's going to be discussing the use of connectivity to link X-ray screenings and laboratory diagnostics. Without further ado, I invite Julius to present.
Thank you, the moderator. Good afternoon, good morning, and good evening, everyone. My name is Tumwine Julius, and I lead the team of developers and other implementers in Uganda that are building a connectivity solution that we call LabxpertsDS Surveillance, or DS for abbreviation. So today I'm going to be taking you through the use of connectivity to link X-ray screening and laboratory diagnostics. Next slide, please. Yes, next one. Yes, so some of the abbreviations that we might see in the presentation include NTLP, which in this case would mean National TB and Disease and Leprosy Program, NTLL, which is National Tuberculosis and Reference Program, RIF, which means rifampicin, MDR, which is multi-drug resistance tuberculosis, and MWRD, which would be molecular WHO recommended rapid diagnostics. Next one. Yes, so significant investment has been made in all TB disease burden countries in connectivity recently. And these connectivity solutions would help us in sending, aggregating, and processing data from multiple instruments that are used in the laboratory. And this can help us in monitoring performance, instrument networks in real time, troubleshooting the utilization of the instruments, looking at reagents and forecasting stock, and also looking at the results for patient management. So it is therefore our WHO and NTLP priority in Uganda, for example, that all MWDs testing sites should at least have a data connectivity solution that is able to transmit results electronically to clinicians and patients. Next one. So this led to the birth of LabXpert, which is a web-based platform. This supports automated data capture. Here, when I talk about automated, it means it is able to pick data automatically without anyone entering this information, as long as there is internet connection. So far, we've been picking data from GeneXpert machines, Florent, Afinion, by Abbott, and now we've done the integration with the digital X-ray. So this, of course, helps us to be able to monitor our equipments in real time. We are able to know which equipments are working, which ones are not working, which ones are well utilized, which ones are not being utilized, which ones are having stocks, which ones are out of stocks. And at the same time, we are able to pick results and relay them to the clinicians and patients in real time. This automated relay is very helpful, most especially in cases whereby the samples are referred from lower facilities to the testing sites, which in most cases are central testing sites. So we are able to send results in SMS format, and as a result, this helps us to reduce the turnaround time of these results. The next one, please. Yes, so in terms of linkage of the lab and the X-ray, this is the process, how it looks. So you have on your left, we have the X-ray, the digital X-ray, in this case, which would be having the CAD for TB. Then we have a central system. In this case, we have LabxpertsDS. Then on the right, we have now another system, which would be the lab equipment. It can be TrueNAT, it can be GeneXpert, it can be any instrument that you are using for diagnostics. So what we do, we make sure that we have a patient identifier. So when they are capturing patient details on the X-ray, we capture in this patient identifier. It can be a unique patient identifier that is generated from a lab information management system or any patient management system, or it could be a barcode in case you don't yet have a system that is able to generate for you these unique identifiers. So when they capture in this unique identifier with the rest of the information, it is uploaded to LabXpert as long as there is internet connection. And even if there is no internet connection at the time of record keeping, at the record capture, as soon as there is internet connection, this result is automatically synced in to LabXpert. So we send now this sample to the lab with the barcode attached to the sputum container or the request form. And then we train the lab technicians also to capture in this patient identifier as the specimen ID in the diagnostic equipment. So also, as soon as the testing is done on the equipment, the result is also uploaded to LabXpert, and then LabXpert has the background job that is already there that matches the two IDs, and it is able to show you that this patient who was tested, who was screened with digital X-ray, this was the result from the lab. Next one. Yes, so in short, the requirements you need for this linkage, it would include the unique patient identifiers, which can be a barcode or any system-generated identifiers. Then you need internet connection on both the X-ray and the lab equipment. Then you would need a central system. In this case, in our case, which is LabXpert, where both systems are able to upload their results. The next one. Yes, so briefly, I'm going to show you a bit of a demo of LabXpert. You can go to the next page. Yes, so this is a screenshot of LabXpert. As you can see, we show you the equipments that are already connected to LabXpert. We have GeneXpert, we have TrueNAT, Afinion, and the different results. The results that are coming in from different equipments. Next slide. Yes, so this is the portal for X-ray. The first part shows you the X-ray devices. So you can be seeing a list of all your X-ray devices that are connected to LabXpert and the last time they last uploaded. So like I've said, this can be real time as long as there is internet connectivity, or in case there is a problem of internet connectivity and maybe you are syncing in this data once a day, it is still okay, the system will keep track of when the device last uploaded the result. Next one, please. Yeah, so the other part is now part of the individual patient scores from the CAD. So the system would be able to show you all the details from the CAD, including the symptom and clinical information. And this helps you to get also an online backup of your systems. And then the other thing is that if you are the administrator or you have a central permission, you can be having access to all the CAD systems in the country that are located in different places in just one portal. You are able to see, oh, this is from this facility, this is a patch, this is a central system, this is from where. In one tool, you are able to monitor and see. And this begins now the part which we talked about of utilization, because now we can aggregate for you this data in a simple dashboard, and you're able to see of which systems, CAD systems, is being well utilized, which one is not being well utilized, and you can be able to follow up different systems. Next one, please. Yes, so the other thing that we can do, we can be able to now also capture the images. And what we have seen is that now you can come up with a quality management system in this case, whereby maybe once a quarter, you can randomly pick system tools that images that were analyzed by the CAD for TB, and you send it to different radiographers that have access to the system. They also analyze and they upload their results, and you are able to compare and see. So this can actually work as a quality management system. You can set it to say, maybe every quarter or every month, I want radiographers in the country together with the CAD for system to analyze the random pictures that I choose. But also, in case you have maybe other cases of the images that are taken and they are not for TB, and maybe you have scarce radiographers that can analyze these systems. So what we have seen is that now we can use LabXpert and make sure that those radiographers have access, so that if a system is, an image is taken from up country, but we have one radiographer who is in the city, can be able to access the system, analyze, and send back the result. This can be for other complications apart from TB or any other just related images that are already analyzed by CAD for TB. Next one. Yeah, then like I've said, you can have summary reports from every site. You can see how many were screened, how many were having scores. You can choose the threshold here by yourself. Maybe I want to see scores beyond 50%, those below, the ones which are not actually images. So one other thing is that when we started picking data from the sites, we realized that this is where you can now also understand how the equipment is being used. Because as if you have seen on the first slide, which was showing the results, you have seen their scores which show -1. And that is when those images are not for the chest, but the radiographer sends them into CAD for TB. So they are being analyzed with the AI, which is meant for the chest when they are legs, skull, and those other images. So also the system helps you to pick up those other images that are being captured that are not for images, but are sent in for the AI analysis. Next one, please. Yes, so this is now the last part, which would be the core of our integration, whereby now for each patient, we are able to show you the CAD scores, but at the same time, we can show you the lab results and the X-ray site and the lab where the analysis was done, and the date for the X-ray and the date for the gene expert. So this one site, this one image has a lot of information back in. First of all, this helps if you want to give access to the clinicians that have requested for these tests. They can have both the screening and the lab results in just one page. Secondly, you can be able to see, in case they are the system is being used in the community for outreaches, you can be able to pick results from multiple laboratories and bring it to one page for a site. So for example, if you have, this is a patch as an X-ray site, but they go to the community and they end up sending these samples to different gene expert sites, They don't need different accounts to get from different laboratories their results. By just logging into one account of theirs, they are able to pick results from different laboratories and they can summarize it. And then the last part you look at is the X-ray and the gene expert or the lab date. So this is where now we can be able to come up with turnaround time. You can be able to know how long does it take from screening to getting the laboratory results. So this one page has a lot of information and a pack that you can analyze either in the system or if you want to download it and maybe take it in Excel and do multiple other analysis. Next page. Yes, so this is what I was talking about in case you wanted to look at the analysis and the different dashboards that we can analyze for you. Next one. Next one, please. Yes, so this is the last part which I would just smuggle in. Since we're already talking about AI, I wanted to highlight that also we have input AI in LabXpert, but this is specifically to help us monitor the lab equipment. And also in future also we intend to, I think, add the digital X-ray in terms of maintenance. So what we have seen is that these equipments, they tend to break down and we know when they have already broken down, and the process of repairing them takes a long time. So we have built an AI model that is able to keep on monitoring the errors and the different notifications that are from these machines, and it is able to notify us at least 2 months ahead before like a gene expert module is breaking down, so that you start on the maintenance process before the machine actually breaks down. So I thought this was, since we are talking about AI, it would be an important part adding, and since maintenance of this equipment is of paramount, this is something that we can think about. Thank you very much. I think that would be my last slide. So in case you need further information, that's my email. We can continue to get in touch. Otherwise, thank you very much, Delft, for organizing this interesting webinar.
Thank you. Thank you, Mr. Julius. It was really insightful. Data connectivity is a hot topic. And I think your presentation today helped a lot of people understand how they can use it to strengthen their healthcare systems. Next slide, please. Now, I'd like to introduce Mr. Jean-Pierre. He is an expert in TB epidemiological surveillance at the Ministry of Public Health, Hygiene and Prevention in the Democratic Republic of Congo. Before he can start his presentation, please note to all our attendees, he will be presenting today's presentation in French. So we request all our English listeners to please click on the English interpretation channel to listen in, unless, of course, you're also fluent in French. And in that case, please feel free to continue here. Dr. Jean-Pierre, the floor is yours.
Okay, merci beaucoup.
Thank you, thanks a lot, Katyayini. And hello to all the participants here today to this conference for experience sharing today. Regarding DRCs, we will share today this experience that we've had in integrating digital X-ray with AI, which we led in DRC for about 1 year, year and a half, with Stop TB's partnership. Next slide. Next slide. So here we have the outline of our presentation with 5 points that we will look through and try to detail in the next slides. Next slide. As an introduction, I would like to note that DRC is part of one of the 10 countries that has the highest burden of TB cases, and TB, HIV, and MDR TB. With a TB incidence which remains very high, estimated by WHO at 317 per 100,000 inhabitants. We have more than 80 million inhabitants, which means that about every year we have about 14,000 cases of TB. In 2021, we had 246,119 notified cases of TB, with 1,614 cases of MDR TB. So in terms of notified cases, we have about 78% of notified cases. And there's also a gap still present. If we want to reach the objective of reducing TB as a problem, we have to reduce or delete that gap. Therefore, we need some approaches and tools that can help us to reduce this gap. Next slide. To get there, the country was helped by Stop TB with the financing also of USAID to contribute and to help the countries to reach that TB elimination through projects that were put in place, introducing new tools project INTP, and this project was financed by USAID, whose goal was to help the different people who were thought to have TB to have access to a quick and sensitive diagnosis and a detection by using ultra-portable X-ray digital with AI. And those who had positive tests results had to have more tests done. This allowed this population to be taken in consideration quite fast. We all know that X-ray is present for a couple years. Back then, we were not really using it. It was back in the back door, and we were not using it. So now we are using it, putting it forth so that we can be more efficient in our results and in the work and in the use of confirmation tests. And regarding the national program against tuberculosis, those radiology services are being put in place, but they are not yet structured properly enough. And the programs are in need of an assistant that can help us to assist and put in place that tool. Next slide. So the country received about 8 different tools, radiology tools, and those tools were placed in 8 health districts on the 519 health districts that the country has. And we chose different sites who were either a hospital in that health district or a health center, a referral health center. And in our early evaluation of those sites, we realized that 4 facilities had already a radiology department, which helped us in that regards. And another criteria of selecting sites, because it was a project that we had started a long time ago, was a good attendance of that structure. For that structure to be easily attended to help us use that element. Next slide. Here's the map of RGC, of GRC, and that project was placed. You can see the different stars in red in the city of Kinshasa. We have city of Mujima Nikassa Oriental, and Kolwezi, and the city of Lubumbashi also. Those 4 provinces benefited from all those different elements present on the 26 provinces that we have in the country. Next slide. Now, what actions or activities did we put in place? First of all, was training. It was a training that was centralized. We identified the 8 interveners who in the four provinces that we noted before. And the training happened in Kinshasa for 3 days. And we learned those people how to set up this radiography and how to use it. Not only how to install it, but how to use it. And it was a demonstration that was done for 3 days. And the participants were really satisfied. So that training was put in place by the Delft team with a radiology technician, with an IT technician, and biomedical technician. Everything was in English, so locally we recruited translators, which helped us to have that French to English interpretation. After that training was done, we installed those different machines. The training was in March 2022, and we installed those elements and those machines in the different provinces. And before that installation, there was an assessment of those trainings they had to receive for those who had to receive those X-ray machines. And that assessment consisted of looking at the premises, because we had to have about 4 square meters to place those machines of digital X-ray, but also to ensure the protection of the population from radiation. We needed to have a source of energy also in those spots. So 7 out of 8 X-ray machines were installed without problem and were operational from July 2022. And one of them did not function properly due to a manufacturing defect that Delft was able to replace a year after to have all 8 working properly. Another activity that was put in place after the training and the installation was maintenance. All the different people present had to have a preventive maintenance training performed by the staff, how to protect the machines, how to ensure that that all the machines were not full of dust, how to have that maintenance that all the people were making in place. And in case of an issue, we had the assistance of Delft team and our local partner here, who's SOR equipment. And this maintenance assistance was done if the technicians were available. So we had to open a ticket, take an appointment to have all the different technicians available to repair the different elements that could break down. Next slide. And those different people trained during the installation of digital X-rays had a support, a great support. The dev team support were able to discuss with them of the different elements put in place, how to use them. We had our assistants, X-ray and TP National X-ray consultant, who helped us to help the people that were trained. We had SR Equipment, which is a local partner who participated to the training, who helped us with all the different maintenance that came after. They really helped us to really understand and use that tools. With Stop TB, of course, we had the quarterly meetings to exchange and to talk and to have different solutions. And then we had a reporting. After that, all those meetings, we had to report data. We know that those data were a presence with the computer that was delivered with all the material. And it was linked to the understanding of our staff and all the elements on the ground. But the different service providers were kind of old. On the new sites, there were newer people, younger people. So it was easier for them to learn about the computer. But for people of a certain age, it was a bit harder to use those tools, the computer, to know how to collect data and to allow for an easier reporting and collecting data afterwards. Next slide. Now, what results did we have in the setting up of those projects? First, we have the 6 first months from 2022, which were the trial months and the learning months. And during those 6 months, about more than 5,300 X-rays were done. And among them, about 1,900 had a score that was superior to 40, which is more probable that those people had tuberculosis. We had 1,300 whose test had to be confirmed. And among those 1,300, about 377 were were TB positive. And then 756 were clinical cases of TB. That was the little challenge that we noticed during that first semester. And from that, we rectified some of our elements and adjusted all the directives and instructions so that in 2023 now, we could better the elements and the different challenges that we were able to face. And in 2023, it was almost 99,575 cases, X-rays that were realized. We had the 3,900 whose score was more superior to 40, 2,900 whose test had to be confirmed, and of them 1,200 whose test was positive. So we had all those cases that were notified thanks to that tool that was used. So you can see indeed that not all of them used the confirmation test out of the 2,900 people. So they were often sometimes done outside the different structures. And they came to start doing all the X-ray shots. But for the confirmation test, it was either through an expert machine, because we already had more than 40 positive cases and people could not wait. So the results were present and people had to see a clinician. Next slide. So now what are the challenges and the issues that we encountered? We can have about 5, and each challenge we had actions taken to respond. The first one was the surface, the space, the structures. Some structures already had X-ray machines, and so the space was reduced. So we needed to find a different room to work in good conditions. Another issue was the training of our service providers, we noticed that we had to train a technician. We trained a technician on every site, at least one technician on every site. But to train one was not enough, indeed, to allow those providers to work correctly. And there was this issue of competency on the use of the tool. So we tried to solve it on the ground by building capacity in the different people who were a certain age. They were able, through this, to do the work properly. Another issue we faced was the problem with the language of the elder. It's not the official, English is not official language here, so the oldest people had some issues with it. To translate some documents in French and to accompany the different service providers. A team was therefore put in place to ensure translation for them. We also worked with a score threshold of 40. It's a score that the country used, because there was a study made before we used all the different equipments. So we had a project of reaching the different scores. But we went kind of wide. We had a number of people who were presumed to be, and this 40 score was used. And we thought after those 18 months of work that there's a need to analyze the data and adjust them. We had some TB clinical cases that were detected. And the last challenges was the cost. The project was free, and then we were able to see what was done to allow a normal functioning. We think that all of this could be integrated in the strategic plan that could use all the different X-ray machines. This way we can see how to finance it. Next slide. Now, what are the lessons that we've learned? First one, it was the link between the X-ray machines and the confirmation test. The fact that we had both of them helped us to better confirm our TB cases. This tool also helped us as a mobile strategy when we did our campaigns in prisons. We were able to bring that tool, even though it's an ultra-portable tool, which means it's easy to carry, but we still had to have a van, so it was not easy to put that tool on our backs. We were still able to carry all of this and to use it in the different prisons. We had a day-to-day support for X-ray consultants. For the adults, there was no problem. For the children, we know that that tool score maybe would not be the same. So every time that X-ray shots were taken for children, we had a call for the X-ray consultants to have an interpretation of the score. And for any, of course, difficulties of tools that we found in different structures, sometimes the score was an issue. So we had an issue with a detector charger malfunction. And all of this with Deathlight, we tried to find a solution there. Next slide. Now, as a conclusion, I said, of course, that this tool of digital X-ray helped the program to better its performance. There's 270 cases of TB that we were able to detect by using this X-ray in test with the molecular tests. Those tools were easy to install. After training, there was a real easiness to install them and to operate them without any serious problems until the end of the second year. We had some issues at first, but we were easily accompanied to help to use it. And so the link between the X-ray and the molecular tests were really beneficial. Next slide. Now, what should we do with the results that we had, and what can we see for the next steps? First of all, we said it, the score has to be revised. We have all the data, we're going to analyze them with our consultants and the support of Delft to see how we can revise that score to be 50 or 60, seeing all the data that we've had from the different sites. This would allow us to solve all those issues of clinical detected TB cases. Of course, reduce cases of repair if we have a national spare parts warehouse. That would be the goal, to have that warehouse with all those different materials, chargers, etc. This way it would make it easier for us to deploy them on site. We have to see that with a Delft team. There's a team to be put in place and service providers to have those people to put in place all that system, to help also the team, and how to we have to figure out how to place them in the different areas, the different health districts. We hope, of course, that we will have soon an AI for the different children's X-ray results. We received the machine. We've had more than 250 results that showed that it was positive and that we had a really good result. We want to increase those number of machines available in the health districts progressively. Next slide. That's it. Thank you. Thank you for your attention. It was maybe a bit long, but I think it was necessary to share that experience. Thank you.
Thank you, Dr. Jean-Pierre. It was a very riveting presentation. Thank you for your insights. Next up, we have Mr. Sohail Siddiqui, who's the country head from Omni Tech, Pakistan. Today, he's going to be discussing the challenges and insights of deployment in Pakistan. Mr. Siddiqui, the floor is yours.
Okay, thank you very much. Hello, everyone. I think just move the slide first. Thanks. Yeah. Hello, everyone. I'm Sohail Siddiqui, as she has already introduced me. I would like to tell you about the challenges we have faced during the implementation of these projects, which is going on through NTP and Mercy-Corp. Before going to this, let me tell that Delft has appointed us in 2022, and we have a very good relationship with them, and they have trained our engineers. They have given us the chance to serve over here in this region. So from last 2022, from 22, we have 5 projects in the pipeline, and 1 project of 12 Mac system has been completed, and 5 project is still in the implementation stage. Can you change the slide, please? Yeah. So right now, 12 has been completed, Max system with the CAD for TB, and other 5 projects is in the pipeline. Now, these 5 projects is from NTP in Pakistan, and one is from Mexico. So we are in the process of doing the training and installation. Presently, even right now, I'm in the implementation of, I'm attending one of the training right now in Islamabad region, and I've just taken out the time to attend this webinar. So right now, so we have completed 12, and now 79 Delft Light is in the implementation stage. Next slide, please. As I've mentioned that the 12 Delft Light was installed in different remote areas in Pakistan, which is near to the border of Afghanistan mostly. So therefore, there was a big challenges over there. We have arranged a centralized training in Islamabad of 12 Max system. So the Delft team from Ghana has been visited in Islamabad, Pakistan, and they have trained our engineers. And after that, we have given them centralized training to the participants. Then it was a very good experience. We have that because these machines was going in the remote areas where they even don't know about the digital X-ray system. They were even living in black and white, time. So it was a big challenge giving them a training. And 3 days training, you have to teach each and everything. And after the training, you have to go and again train them, because this training is just to introduce them to what kind of product is this and how is going to be work. Because CAD for TB is again a challenge for them, because they never used these kind of softwares in their regions. So the Delft team has, with the collaboration of Omni, giving them a very good training, which is, because of that, we have implemented about 12 systems in Pakistan. It's perfectly working over here right now. Next slide, please. So now come to this 12 system. We have faces a lot of challenges. And you can imagine that in third world country, in Pakistan, there's a lot of challenges, especially in remote areas where there is no light, where there is no water, and basic necessities are not available. So in these areas, when you are going to implement such a sophisticated machines over there, so we faced a lot of challenge. And one of the challenges was the room preparation, because they were not used to of these rooms, these kind of rooms there where the lead is over there, and where they have to wear the lead apron and all those things. They're just working just like that. So we initially, with the help of Delft team, we have given them that, okay, we required such type of room. They have to prepare it for the patients, because there the TB patients will be screening. So there should be a special area over there. So we have converted, and you can see in the pictures that these were the places where we have converted into very good rooms, which is
available for X-rays for TB patients, including the air condition, although there is no light. I mean, there's the issues of light, but they have arranged each and everything to give them a support for the electricity. Then the next challenge was like the transportation. The NTP transportation to these areas, to remote areas, is again to hilly areas. All these are the hilly areas where there is no road. So reaches to that place, all the system in intact condition, that is again a challenge. But I think that NTP has managed everything, and the machine has been reached in very good conditions. There's nothing, no issues and no problems. Then the other challenge was the language. As I mentioned that this is a third world country, and the lack of education and all those issues over here. So especially in remote areas, not in the city areas, you'll find, I mean, everything over here, but in the remote areas, only there's a language barrier. They can only speak their local language. And in the local language, you have to give support over there, and you have to teach, you have to train, and so that they can use that machine perfectly. So they are now using it. So now, as I mentioned that, I mean, the infrastructure was not good. Then the communication, and especially in these areas, the communication, like internet facility. There is no internet facility. When there's no light, then there's no internet. Even internet through the mobile is also not possible, because mobile is also not working in these areas. It's all hilly areas. So again, that was a challenge, but we managed it. And how we managed it, that's a very, very tricky thing, I mean, how we managed everything. But now everything has been installed and it's going very good. Then the last is the safety. Safety means that, in some of the areas where the machine has been installed, this areas is being near the border of Afghanistan. And you can imagine that militants, there's a war going between the Pakistan army and the militants. And during this, we have to implement each and everything over there in the hospitals, in the district hospitals. So safety was again an issue for our engineers, our team, but Alhamdulillah, we have managed everything. Next slide, please. As far as as I've mentioned that, okay, 12 Mac system has been, trained and everything has been completed. Now we are in the process of 79 Delft Light CAD for TB is in the process. And presently we are giving them a training in 5. We have selected that we are going to give them a training in 5 districts. We have selected 5 districts, and we are going to give them 5 centralized training in these areas. And all the participants, like, minimum, 20 participants is available for this training. And it's like, more than 100 people will be trained at the end of this year. NTP and Mercy Corp are, together working to ensure smooth training and installation. Yes, I have meeting with number of times with Mercy Corp and NTP. Both are very supportive. They are working hard, and they're very helpful. Their team is very efficient. So we have a very good communication between these two, and we are working very good in this region to implement these 79 machines to work over here. And then the people curious about the CAD for TB and how to the AI combat in TB. Again, it's the same thing which I've mentioned earlier, that lack of education, lack of computers and all those things, gadgets, they are not used to of that. And how can they go for the AI? But we try to train them, we teach them. Even now we are receiving the calls, but we are giving them a support on the phone and online and everything, so that these machines will be running and the patient will be benefited mostly. Please, next slide. Thank you very much. In the last, I must say that, the one of the challenge was about the time difference, which I just forgot to mention that we know in Pakistan, the time difference is like five hours to Netherlands, and same is the African Ghana. But the team of the Ghana is always available because my team cannot work when the hospital is running, when the hospital is working. So we have to go in the evening or the night to work. And at that time, in some time in the midnight, my engineers are working, and the support team of Ghana and Netherlands, they are working with me even in the midnight, even on the holidays. And that's really, something I cannot say because, once you are on holidays and you are giving them support to our team also. So thank you very much for everybody. Thank you very much. Yes.
Thank you, Mr. Siddiqui. It was very interesting to see how you've been supporting us and our partners, one of whom will present right after you, in installation and the deployment of all these solutions. So coming up next to present the other side of the same installation story, we have one of our really esteemed partners, Dr. Adeel Tahir, who's the director of TB program at Mercy Corps, Pakistan. He's going to be discussing the use of AI, specifically CAD for TB, for the TB detection experience from Pakistan. Hello,
Thank
Dr.
you,
Tahir.
Katya. Thank you very much. And I hope I'm loud and clear. Next slide, please. Yes. So I'm going to present our experience of using CAD for TB for the detection of TB in Pakistan. Next slide. Next slide, please. Yes. I just like to briefly, previous slide, please. I'd like to briefly update the audience about Mercy Corps. Mercy Corps is an international organization that is working in 40 countries in the world. And in Pakistan, Mercy Corps is working since 1986. In TB program, Mercy Corps is principal recipient of global funds since 2007. So continuously over the last more than a decade, we are working in TB control initiatives in Pakistan. And mostly these initiatives are for private healthcare sector. If I talk about the TB prevalence in Pakistan, unfortunately, Pakistan ranks 5th among the high burden countries with regards to tuberculosis. As per the last global TB report by WHO, should I continue? Yes. As per the last global TB report by WHO, there were 600,000 cases that were produced in Pakistan each year, and Mercy Corps and National TB Control Program were able to identify 470,000 of these cases. So still there are certain cases who are missed from notification, and mostly these are the patients who are unaware of available TB services or who are in areas which have limited access to healthcare services. So what we are trying to do is to enhance the reach of these underserved patients to our health facilities, either through the availability of the healthcare services or we are directly reaching to them. And that the main impact of doing that is to reduce the transmission of tuberculosis and decrease the morbidity and mortality associated with disease. Next slide, please. Yes. As I mentioned, what we are trying to do is we are providing both active and passive care services for the patients suffering from tuberculosis. In Pakistan, we have taken on board more than 13,000 healthcare facilities from private sector. These are the privately run GP clinics that are working with us in 119 districts. But still, there are certain areas where the patients do not have access to these services. So we have designed an intervention of active case finding for these patients. We have arranged 40 mobile vans that are equipped with digital X-ray machines with CAD for TB software and GeneXpert machines, and we organize chest camps in the areas which are far-flung from the main health facilities. So you can see that from this slide that we are covering 89 districts through this intervention, and all the provinces of Pakistan are covered. And we are working with 6 partners for TB care services. Next slide. Yes, please, next. Yeah. So how CAD for TB is helping us in this active case finding of TB patients? The best thing that CAD for TB has done, that accuracy of diagnosis has been increased. When we use the score generated by CAD for TB, our physicians who are in the chest camps, they are quite comfortable and confident that ordering the sputum sample for these patients for GeneXpert would yield results, and the accuracy of software is quite high. I will explain the data in the next slides. Then the diagnosis is quite rapid when we use these X-rays as a screening tool. And also it is very cost effective because in Pakistan, we cannot take trained radiologists to far-flung areas with us so they can read the X-rays. So through this technology, the X-rays images are read and a score is generated. And based on the score, we identify whether the person is suffering from tuberculosis or not, and we label them as TB presumptive accordingly. Next slide. Yeah. So we are implementing these services through 40 mobile vans. And as I mentioned, these are equipped with digital X-ray machines with CAD for TB software. And also all these mobile vans will now have GeneXpert machines. So on the spot screening and diagnosis of TB patient is possible even in far-flung areas of the country. And it has allowed us to identify TB patients more and more. Just give you an example that in last month, we have conducted almost 600 chest camps through these 40 mobile vans, and our average case yield is 2.5 patients per chest camps. So we have identified around 1,500 TB patients through this intervention. The vans go into far-flung areas. We have 3 staff members on board with us. One is van driver, one is GeneXpert technologist, and one is medical imaging technician to use these digital X-ray machines. When we go into the far-flung areas, our district team already present in the district, they have arranged chest camps, and there are around 100 people that are present usually at the site of the chest camp. So we screen them using these X-rays and CAD for TB, and those who have score more than 60 or who have symptoms of tuberculosis, we order sputum testing for them through GeneXpert, and then on the spot diagnosis is made possible. Next slide. Yes, as Sohail Saab has mentioned, now we are in the process of upgrading our active case finding services through the 25 portable X-ray machines that we have already procured. We are in the process of hiring X-ray technicians for these 25 portable X-ray machines. And then once these technicians will be hired, we are planning to train them through the support of Sohail Saab and Delft in the month of June. So once these technicians will be trained, we will deploy these 25 portable X-ray machines in 25 districts of the country, which are definitely high burden districts. So the idea would be that these machines will be placed in selected hospitals or health facilities, and we screen the patients through X-rays. But we also take these machines in the far-flung areas or in areas which are not accessible by our mobile vans because of the narrow roads and other issues. So we take these machines into the far-flung areas and screen the patients, particularly the contacts of TB patients, and through these X-rays. If the X-rays of these contacts are found clear, we offer them TB preventive services. So through this X-rays and CAD for TB, we are not only diagnosing TB patient, but we are also trying to offer preventive services through this intervention. Next slide. Next slide, please. Yes. Now I'd like to highlight the data. We have recently completed our last grant that started from July 21 till December 2023. In this grant, we have conducted a previous slide, please. Yes, we have conducted 5,910 chest camps, and we did X-rays of 155,000 people. Out of those 155,000 people, we found that the people who have scored more than 60 were 24,000. But there were 131,000 persons who have scored less than 60. When we order gene expert testing for the persons who have scored more than 60, we found 2,000 cases. And so the percentage of detecting tuberculosis in persons with high CAD for TB is 8.3%, which is quite high as compared to the persons who have scored less than 60. And the yield in those who have scored less than 60 is 1.7. And just for the information of the audience, as I mentioned, that we take a doctor with us for these chest camps, and sometimes based on the symptoms, even if score of CAD for TB is the patient. But definitely, if the score is higher, you can see that the yield of tuberculosis is quite high, and a very cost-effective intervention. Yes, next slide. For the data of this year. Yeah. So
Hello, Dr. Tahir. Are you there? I'm sorry to everyone who's
yes,
listening in.
I'm back.
Yeah, oh, perfect. Thank you.
I'm back. I think it was a disconnection. Okay, so
Yeah,
I was
it's
talking
absolutely
about the
fine. You
data
can
for this
continue.
year.
Yeah, thank you.
Thank you very much. We have conducted 645 camps from January till March this year, and we have conducted X-rays of 32,000 persons. Again, we have found that 3,472 persons have scored more than 60, while 28,000 have scored less than 60. When we did gene expert testing of the person with score more than 60, we found 408 TB patients, and the yield is 12%. But in those patients where the score is less, we have just found 184 MTB detected cases, and the yield is 0.7%. So clearly it shows that CAD for TB is helping us in identifying more and more TB patient, and also it is very cost effective because we only order gene expert testing for those patients who have high scores. And from this intervention, we have also so far found 13 drug resistance TB cases as well. So next slide, please. I would like to discuss some of the challenges. Okay. The challenges through this intervention are very few, but I like to highlight for the purpose of this webinar. Yes, the CAD for TB boxes are helpful for us, and they work in offline mode with the areas where we have limited internet connectivity. But if we have to do some troubleshooting, then we need reliable internet connectivity. So we are having some issues, particularly in those areas where we have limited internet connectivity. We are facing some logistic challenges through this intervention. Yeah, these are not directly related to CAD for TB, but for the mobility of our mobile vans, taking staff with us to different districts, this is a big challenge, but we have learned so far, and we are trying to continue this intervention in the next 3 years at least. Then the acceptance within healthcare workforce, initially the doctors were reluctant and they were not relying on this CAD for TB technology. Instead, they rely on reading the X-ray imaging themselves. But with the passage of time, our experience for the last, I think, around 5-6 years using CAD for TB, now the doctors are very much reliant on this technology, and they prefer to use the score for diagnosis of tuberculosis patient and for ordering gene expert testing. So this is a brief overview of the work that we are doing, and we are thankful to Delft Imaging for helping us in this important intervention. Thank you very much. If you have any questions, I would like to, I'm happy to answer. Thank you very much.
Thank you, Dr. Tahir. I would like to pass the mic to my colleague Florent for the Q&A session.
Thank you, Katja, and thank you very much again to all of our speakers. We have about 5 more minutes for scheduled for the Q&A, but for those of you that haven't joined our webinars yet, we always answer all of the questions. If we don't get to them in the live sessions right now, we do send a Q&A sheet afterwards. So all the questions that you have asked, we will align on with the different speakers and answer them accordingly. But I wanted to pick a couple of them out because I thought they were interesting. And let me start with a question for Dr. Adeel. And the question was, let me bring it up over here. The question was from Adi Sanjaya, who mentioned that in my region, many radiology specialists, they reject the presence of AI technology for chest X-ray interpretation because they are worried that technology will replace them. Does the same resistance exist in Pakistan? And if yes, how do you manage this?
We do not have such kind of issues. As I mentioned, that we mostly work with general practitioners, and most of the general practitioners are not very much confident in reading an X-ray image. So initially, they were reluctant on relying on this technology because they were not sure whether the results of this technology are good or not. But as I mentioned, the data, with the use of the data, we were able to convince them, and they are now very much confident, and it is not an issue. As mentioned in the question, we did not face that issue in our country. Thank you.
Thank you, Dr. Adeel. And a question also for Dr. Jean-Pierre. There were quite a good number of questions in the chat as well. Also, some asking about how do you look at the maintenance and support to make sure that the systems can be used sustainably for a longer term? You mentioned some elements that would be helpful, like having local spare parts on the ground. Are there other elements that you could think of that could be helpful in DR Congo in the implementation?
Oui, je pense qu'on a réfléchi.
I think that we thought about this question a lot more in the last trimester of this year, because this is a dotation that we received, and the different exams that were made with that machine were free, mostly for chest X-rays, where we have AI included. But those machines can also do all the different other exams where we would need an expert interpreting those images. And those other exams are not free. And we think that with that investment, that cost could maybe pay all the maintenance services, because we have a local partner there, a Delft local partner here, who could ensure that maintenance. Another possibility, as we've said, we want to integrate it in the finance request for the national fund to ask for a grant. But that grant we'll have to see with time that also the other exams could be paid this way. This would help us to have locally also a warehouse for all this material that we could use.
Sure. Thank you, Dr. Jean-Pierre. That's very helpful. Yeah, I think also from our side, I think it's very good, like Dr. Jean-Pierre is mentioning, how do you financially sustain it after the project? And there's an element of, would there be a different grant or new global fund round available for this or other types of funding, but to also look at measures to help finance some of this maintenance within the country, as Dr. Jean-Pierre mentioned. I wanted to also highlight that there is the TB burdened countries and the challenges that they face. It is so varied, of course, and we have people from all across the world dialing into this webinar, and the challenges in Pakistan would be very different than the one I saw. We had attendees from Malawi or from DR Congo, and what we see in a lot of cases, if you have connection on the ground and, for example, a little bit of 3G or 4G connection, or at least a phone connection, then our help desk together with local partners can solve a lot of the issues already remotely. But of course, the reality is also that there are certain sites, and I think Dr. Jean-Pierre also faces this with some of the sites in DR Congo, and also Sohail talked about it, that they have this in Pakistan who don't have any connection at all. So there's little electricity in some of the parts where they're placed. Phone connectivity might not be there. And then, of course, support becomes more challenging. And then you see also that the troubleshooting times and how do we assess whether something is broken or not becomes a lot more challenging than, if you have 3G internet like you would have on your phone. We can remotely dial in, for example, to the CAD4TB station and see what the problem is. So I think that is something also from our side, that having a bit of a SIM card with the teams that are implementing it is incredibly helpful, because it does make sure that on the ground we can also tackle and troubleshoot quite quickly. I'm already going a little bit over time, but I wanted to share a little bit more about some of the questions, just answer some of the questions we can answer. There was one question: can we use CAD4TB for detection of diseases other than TB? Yeah, so CAD4TB, it's specialized really in TB screening, but we also have CAD for silicosis, for example. For silicosis detection, there is a meeting actually on silicosis and CAD detection end of July, I believe it is, or end of June it is, in South Africa. If you are attending that, please let us know. And we also recently launched CAD4TB8, which has a score for TB abnormalities and a score for other lung abnormalities. And this is something that where the CE is pending, and we're hope that this comes through in the coming months, in the coming 1 or 2 months. But auditing bodies are very busy, so we're just waiting for the release of that. Everybody that already has CAD4TB and has a warranty contract under that, they will be upgrading also, will be upgraded to this newer version. For example, also the folks from Pakistan and the team from DR Congo here. I saw a lot of questions about radiation safety. I wanted to bring those maybe together as far as I can. With the Delft Light, we do provide a lead apron for radiation protection, and we also provide guidance in the training on how to safely set up the system, get the right setting, people around it, the right distance, and so on. So we try to provide as much guidance on that as we can. There was a question whether we can share the list of countries where the portable X-ray has been approved. I can share at least a list of where we have implemented the Delft Light. It's about 40 countries at the moment around the world. By the way, you can also see all of the implementations that we've had very transparently on our website to see what has been implemented there, how this was approached. And you can also see all of the previous webinar sessions also on our YouTube channel, for example, and they're also on our website. So many, if you're from, for example, Malawi or working with IOM or from Uganda, we've had many speakers and webinar sessions before, and they're all recorded there so that you can see them and review them again. I apologize, but I think I'm gonna stop it right here because we're already a bit going over time. Again, I want to emphasize we will answer all of the questions. We will follow up by them. Everybody who has registered to this webinar, you will receive the recording. You will receive the Q&A sheet with all of the questions answered. I want to very much thank our speakers today. Julius, fascinating presentation. I think the work being done by the NTLP in Uganda and the team working on LabxPert, it's really quite revolutionary, this type of connection in a national surveillance platform. It hasn't been done yet in this way, so it's very interesting. I very much appreciate all of the insights from Dr. Jean-Pierre from DR Congo. Very interesting presentation and highlighting also the challenges that the implementation faced, which is, I think, something everybody can learn from. I want to thank Sohail, our partner in Pakistan, for a very lively presentation, a very real presentation about some of the challenges that you face in a rollout like this, whether it's challenges in connection or across the border with where militants about and so on. Very much appreciated. And Dr. Adeel Tahir for the very extensive experience that Mercy Corp has in Pakistan working with these kind of solutions, and your willingness to share those with all of us today. So thank you again for joining us. And if you don't know yet, we have these webinars on a quarterly basis. So we hope to see you again in the next one. Thank you, everybody.
Thank you. Take care. Bye-bye.
Merci à tous.
Thank you. Take care. Bye.